All right. Good morning, good afternoon, good evening, everyone. Thank you so much for joining us on today's webinar titled Strategies to Engage the Private Sector in Family Planning and Reproductive Health, Insights, Experiences, and Lessons Learned from Asia. And thank you all for introducing yourselves in the chat. It's nice to be with you all today. If you haven't already, please do introduce yourself in the chat, and you'll also see that we've posted a link to a form that we'd ask all of you to complete. We'd love to hear from you regarding what additional family planning and reproductive health topics you're interested in hearing more about. So if you have 1 minute to complete that form, we would really appreciate it. Next slide, please. I am Ann Ballard-Sarah, and I am a Senior Program Officer on the Knowledge Success Project. And I am very excited to introduce our amazing panel of speakers for today's webinar, including Dr. Vinit Sharma, who's the Regional Technical Advisor for Sexual and Reproductive Health and Family Planning with the UNFPA Asia Pacific Regional Office in Thailand. We also have Estrella Jolito, the Local Partnerships Officer with RTI International, Philippines, and Sristi Shah, Senior Communications, Documentation, and Knowledge Management Specialist for Momentum Nepal with FHI 360 Nepal. Next slide. For today's webinar, Dr. Sharma will begin with an overview of the importance of private sector partnerships for family planning and sexual and reproductive health programs. Australia will then provide insights on private sector engagement for family planning in the Philippines through Family Planning in the Workplace, a matching model. And Sristi will share insights and experiences from Momentum Private Healthcare Delivery Nepal and their approach for scale up. So please be sure to type any questions that you have for any of the speakers in the chat, and we'll have time for a Q&A and discussion amongst all the speakers at the end. And finally, a quick note to say that we are recording this session today, and we'll be sharing the recording and the slides after the webinar. Next slide. So without further ado, I'd like to hand it over to Dr. Sharma for his presentation. Over to you.
Thank you very much. Dear friends and colleagues, it is indeed a pleasure and a privilege to participate in this important webinar. At the very outset, let's have the next slide, please. At the very outset, let me start by saying that all governments are committed to ensure universal health coverage and reaching the last mile. However, many governments, especially those in the developing world, do not have the necessary resources to fulfill their obligations. This brings us to the issue of partnerships, a modality that has been identified as an important accelerator. Partnerships involve identification of organizations with similar goals and deciding on ways to work together. Next slide, please. Government partnerships with the private sector. The private sector, let's not forget, is endowed with better efficiency and better outreach, can translate into health of the people, by the people, for the people, a true democracy of health. And it helps to increase access, availability, quality, improving the efficiency of services, and also job opportunities for young people. Next slide, please. The model of public-private partnership that we often talk about is actually made up of 1, corporate social responsibility, 2, social marketing, 3, social franchising, and 4, contracting. Contracting would mean contracting with individual private practitioners or individual healthcare providers that are not a part of a whole range of corporate private sector. Next slide, please. The whole idea of social marketing is not new. In the 1970s, Kotler and Zoltman had said that marketing principles that are used to sell products to consumers can be used to sell ideas, attitudes, and behaviors. The primary focus, let us remember here, is on consumer. And marketing talks go to the consumer and do not talk about the product alone. Let us also remember in this context that preventive services like SRS services are often less attractive to draw resources as compared to the lucrative curative services. And hence it becomes more important for governments and for partners to explore partnerships in the preventive services or public health services. Next slide, please. Social marketing or partnerships with private sector often undoubtedly do well in motivating individual behavior changes by applying the principles of mutual exchange. Here you have the partner, the government, and the consumer all exchanging ideas, views, needs, and requirements. Such successes are to be expected. This is natural because, as per the predictions of the economic theory, the health services, these goods are less subject to market failure. Next slide, please. In the past, there have been successful public health interventions like childhood immunization, and governments partnered with the private sector. The polio eradication example, the examples of ORT, the examples, we can go on and on about these examples. These examples have all been examples of very successful government partnerships with the private sector. It is also because of high service readiness scores in the private sector, convenient operating timings. The government sector, we all know, would operate at a certain time, which might not be convenient to males, might not be convenient to young people, and also the locations might not be convenient. So the partnership with the private sector is really helping us overcome these obstacles. And then easy access and acceptability to young people, because the private sector cuts into a lot of obstacles created by red tapeism and by formalities. Next slide, please. So we have seen that the experience in the past experience has been successful. What we need to do more for the future. One, let us not forget that this is not making services available in a larger area. It is also important to think of making available new services, not the expansion of old services alone. And then the private sector with a high pricing could be an obstacle for utilization by low-income groups. Number two, as in the government sector, the private sector should also continue to focus on involving the community and men. We always talk about male involvement, but male involvement is mostly lip service. The partnerships with the private sector can really encourage male involvement. Another factor that needs more focus would be on availability of valid and reliable data from the private sector so that it can facilitate monitoring and assessment. And finally, as in the government sector, it is very important not to forget provider bias and prejudices. Taking care of these would ensure that any partnership with the private sector would go on to become a successful, not only a project, but a successful national program. Thank you very much.
Thank you very much, Dr. Sharma, for that really interesting background on the topic. If you have any questions for Dr. Sharma, please include them in the chat and we will address them during the Q&A portion. Before we continue with our next two presentations, though, we'd love to hear from you all if you've engaged the private sector in your family planning and reproductive health work in the Asia region or beyond. So please take a moment to respond to the poll question that you should see on your screen now. The question is, have you engaged the private sector in your family planning work? Yes, no, but I plan to, or I'm not sure. Great, I see the answers coming in. It looks like 85% or so have engaged the private sector in their family planning and sexual and reproductive health work. If you are among that group of people that has, we would love to hear your experiences in the chat as we go throughout the session today. All right, I see most people have responded, so I'm going to give you one more minute to participate and then we'll look at the responses. Okay. All right, so it looks as though 76% have engaged the private sector, 7% haven't, 12% haven't, but they plan to, which is wonderful. I hope you're able to glean some insights and lessons learned from today's presentations. And 5% have said, I'm not sure. So I'll reiterate, for those 76% that have, we would love to hear your experiences in the chat as we go along. Right, thank you, everyone. So next, I would like to hand it over to our next speaker, Estrella Jolito, to discuss the matching model in the Philippines. Estrella, over to you.
Thank you, Anne. Thank you, Knowledge Success, for this opportunity to share the Philippines' promising practice in engaging the private sector for family planning. Next slide, please. Next slide, please. Okay. Engaging private sector for family planning in the Philippines has been a challenge for decades, despite the mandates being in place, such as Article 134 of the Labor Code of the Philippines, the Department Order 56-03 of the Department of Labor and Employment, and Executive Order number 12, otherwise known as Attaining Zero Unmet Need for Family Planning. Next slide, please. So to address the implementation challenges, USAID's despite the mandates, the implementation of the family planning in the workplace were not sustained, and some companies have not been able to start up yet. The top 3 reasons were the fast turnover of company nurses and clinic staff, and the lack of skills of company nurses and midwives to provide or perform the services because they were not trained, and the non-procurement of family planning supplies by the companies. Next slide, please. Next slide. Okay. So to address the implementation challenges, USAID's Rich Health Project collaborated with the Department of Labor and Employment, the Department of Health, the Commission on Population and Development in implementing the family planning in the workplace program matching model. So these 3 agencies agreed as they find the model very practical and sustainable. And they agreed to test the model with Gaisano Capital in Pagadian City, Philippines, and with Ocean Deli Packing Corporation in General Santos City. The companies then were paired with Mom's Birthing Home, Family Planning Clinic, Jensen Medical Center. Next slide, please. So as part of the process, consultation meetings were conducted with the collaborating partners. Then partnership meetings between the companies and the service providers were facilitated to discuss agreements as far as their roles and responsibilities are concerned. And this was followed by the signing of the Memorandum of Understanding to formalize their partnership. Next slide, please. Now, let me share with you how we did the matching process. To get the baseline, the company conducted rapid family planning profiling with employees, and the results were analyzed and used for action planning. Then service facility mapping and facility assessment followed to identify the capacities of the service providers, including their needs. Then partnership meetings were facilitated together with the collaborating partners to discuss the respective roles and responsibilities, and of course, to generate commitment. Then, to establish the partnership, they signed a Memorandum of Understanding with the support of the Department of Labor and Employment, the Department of Health, the Commission on Population and Development, and the local government units. Implementation started immediately, right after the agreement was signed. Then monitoring was conducted every quarter to document the results and lessons learned. And the family planning accomplishments were also submitted to the City Health Office. Next slide, please. Now let me share the baseline assessment result of Gaisano Capital. Using the rapid family planning profiling tool, the results showed that majority or 65% wanted to have another child in the next 4 to 6 years, but only 3% are using a long-acting method. while 56% are not using any modern family planning method. The reasons ranges from fear of side effects, myths and misconceptions, and most of them said that they don't know where to go for family planning services, and this comprises 35% of the total respondent. Hence, there is a high unmet need for family planning among the employees of Gaisano Capital. Next slide, please. So using the results, action planning was done. Mom's Birthing Home partnered with the Population Office, the Provincial Health Office, and the City Health Office in conducting series of demand generation activities. They used the Enhanced Usapan. By the way, Enhanced Usapan is a participatory and conversational type of health education with service provision immediately. So this resulted to a total of 119 family planning acceptors for the first quarter of the implementation. Then the City Health Office have observed the increasing demand. Hence, they committed to allocate family planning commodities and supplies for the company employees for the succeeding quarters. Ocean Delhi Packing Corporation also showed the same result. And because of this, General Santos City Health Office allocated the supplies regularly to Gensan Medical Center for the employees of Ocean Delhi. So we also noted that company support have become more flexible. Internal system was installed to allow the employees to extend their health break to a maximum of 1 hour should they go out of their station to avail of family planning services. And Dolly adopted the matching model and started to conduct rollout activities, orientations and consultation meetings of member companies are now ongoing. Next slide, please. So like any other project implementation, the matching model also encountered challenges. So one of them is that there's a very limited number of FP-trained and PhilHealth accredited private service providers where the companies are operating. And the facilities that were paired with the companies have also experienced turnover of clinic staff. On data management and utilization, there is a lack of appreciation on the data and information gathered because the service providers are more focused on the service provision, and some records were mixed with the regular clients. Next slide, please. So what we did, so as our adaptive solutions, Rich Health collaborated with the Association of Private Health Service Providers to establish family planning standalone clinics, especially in areas where there are no or very limited number of private family planning facilities. So we linked the private service providers with the Department of Health, the Provincial Health Office or City Health Office for their capacity building needs. And we also provided technical assistance in the accreditation process with PhilHealth, including family planning tagging of the service provider so that they can reimburse the services rendered so that they can sustain their delivery of services. The reimbursements, by the way, also serve as their professional fee since the company will not be paying for the health service provider's salary. Now, we also provided technical assistance to the private hospitals and infirmary clinics so that they will become family planning service delivery points as well. And we also maximize the pause and reflect sessions for data utilization and action planning. Next slide, please. So what have we learned from the implementation of the matching model? So we highlighted 3 important lessons that we have learned. One is that during the pause and reflect sessions, the HR, the human resource managers of Gaisano Mall Capital and Ocean Delhi Packing Corporation recognized that the availability of free family planning services in the workplace has benefited both the employees and the company. The system that the HRs installed makes communication more frequent and open, which led to an improved management and employee relationship. Employees also shared that they are happy because they need not apply for undertime or be absent from work to be able to seek family planning services. Also, we have noted that the key elements when implementing family planning in the workplace is its adaptability, effective communication, flexibility, and strong collaboration with, especially with the Department of Labor and Employment, the Department of Health, Commission on Population and Development, and their local counterparts. Also, the signed partnership with clear definition of roles and responsibilities and the clear understanding on the benefits of both parties have helped sustain the delivery of family planning services in the workplace. Okay. Thank you. I think that ends my presentation. And thank you for your undivided attention. Would be glad to entertain questions later. Thank you.
Thank you so much, Estrella. That was a very interesting presentation on the matching model. If you have any questions for Estrella, please write them in the chat and we'll be sure to address them shortly. I've seen a few questions come in already, which is wonderful, so thank you all. I think we are ready to move on to our next presentation. So now I'd like to hand it over to Srishti Shah to discuss insights and experiences from Nepal. So Srishti, over to you.
Thank you so much. Hello, everyone. Namaste from Kathmandu. And I'd like to start by thanking you all for this opportunity to be able to share on behalf of our entire team, the USAID-supported Momentum Private Healthcare Delivery in Nepal, which is implemented by FHI 360, PSI Nepal, and Nepal CRS Company. So I will be sharing our project's approach and experience with engaging the private medical sector in Nepal to improve access to high quality of family planning services and how we are scaling up our approach in additional private sector sites across expanded geographies. Next slide, please. So I would like to start with the context that we work in. It is very important for young Nepalis to be able to access quality family planning services from the private sector because one, there is high unmet need among adolescents and youth. And two, not only is private sector an important source of family planning, these adolescents and young Nepalis are the very groups who are more likely to access family planning services through the private sector. Now in Nepal, policies and government guidelines do promote public-private partnership to strengthen health service delivery, and they encourage private providers to play an expanded role in the National Family Planning Program. But in reality, there are very few policies and plans that actually include practical adaptations to support delivery through the private sector. So this has resulted in not much support being provided to the private sector to improve quality of their services. Next slide, please. So designed to improve family planning services from the private sector, particularly for young people, Momentum Nepal works to improve both technical and managerial capacity of private sector sites. Next slide, please. Now, Momentum Nepal initiated its pilot phase with 105 private health facilities and pharmacies. And in scale up, we will be engaging 811 new private sector facilities and pharmacies. So it's an 8-fold expansion across new geographies and contexts. Now, in both phases, you will see that we work with a majority of pharmacies. And at facilities like hospitals, clinics, and polyclinics also, we primarily work with pharmacies, as in our context, that is where clients mostly come first for their family planning methods. And we do have referral mechanisms in place for methods that are not available. And for ease of presentation, from now on, I will refer to pharmacies and facilities as sites. Next slide, please. Now, I would like to summarize the project interventions that formed our family planning approach with the private sector. In the pilot phase, the project worked with the 105 sites, like I mentioned, to improve their technical capacities, which you will find listed on the left side of the screen. This was done by training them in adolescent sexual reproductive health and family planning counseling, and use of DMPA injectables by paramedical cadre, like community medical assistants, health assistants, auxiliary health workers, etc. And the project initiated quality improvement processes where family planning mentors, they conduct quality assessments every month using a standardized digital checklist, and also review client feedback to ensure that services are being responsive to client segments. Also, the project designed a simple data collection and management system for the purpose of, one, enabling facilities to use data to drive their service delivery and in forecasting commodities, and two, also for initiating the feeding of data from facilities into the national system to highlight the private sector contribution. Now, on the right side of the screen are elements from the business component. To link improved quality family planning service delivery to customer loyalty and improved business, a business skill training was provided, which included skills like stock and financial management, developing business plans and strategies, and improving customer responsiveness, among others. Additionally, skills for health facilities to create demand for family planning services were also provided to site owners. Targeted community mobilization efforts were also carried out in our catchment area to provide knowledge on adolescent sexual reproductive health and informed choice, and also to improve linkages with the project-supported sites where there were trained providers. In addition, monthly provider cluster meetings were carried out to support greater evidence use and generation. Also, quarterly meetings were organized between municipal authorities and private providers for better collaboration in family planning. Next slide, please. As part of our scale-up design, the pilot sites are moved from intensive monthly support to a less intensive quarterly support by the family planning mentors. The purpose is to encourage private providers and owners to practice skills and networks and to be more self-reliant so that the project can eventually exit, and we hope that the work will continue. One of our strategies to move from the intensive to less intensive support and sustain gains over time, even after the project ends, is to build an enabling environment for the private sector family planning provision for adolescents and young people. So at the local government level, regular engagements with authorities were prioritized in the pilot phase, and they are being continued so that they can take on some of the roles and responsibilities that the project intensively supported with. The project is also working to build the local implementing partner, Nepal CRS's capacity to offer technical support to private sector sites and support for commodity supply. And for private providers and owners, we hope they will maintain the use of dashboards through an option of self-assessment. And provider cluster meetings also have the potential to continue engagement with the government that the project had initiated. Next slide, please. I'd like to share a few reflections from the pilot phase data. Now, next slide, please. So on the upper part of the slide, you will see that from our pilot phase sites, 158 private providers were trained in government certified adolescent sexual reproductive health, or ASRH, and also in value clarification and attitude transformation trainings. And 180 providers were trained in injectables. Also worth highlighting is that during our first assessment, only 14% of the sites had set aside counseling rooms or spaces. And in response to monthly quality coaching that highlighted the importance of privacy, by October 2022, all site owners organized or restructured existing space to make available counseling rooms or spaces. Now, let me highlight some family planning counseling quality data as defined by the Method Information Index Plus from our pilot phase, given its importance in family planning uptake and continuation. In the lower half of the slide, you will see that the data on these 4 questions from the Method Information Index Plus on side effects and side effect management and method switching reflect that all sites have not only improved, but over 9 out of 10 sites have maintained high standards of counseling as per our most recent assessment. Next slide, please. So for monthly client visits for short-acting contraceptives for 2022, the data on the left side of the screen reflects that more than 200 client visits per month per site, of which 20% were adolescents and 46% were young people. And the main contraception preferred by these clients are condoms, emergency contraceptive pills, and oral contraceptive pills. We would also like to highlight the gender perspective on the right side here, as a substantial number of males purchased ECPs and OCPs for women. Now, the number of male visits has considerable programmatic implications that we are having to reconsider in our scale up to ensure that our counseling approach is responsive to males as well as females visiting the sites. Next slide, please. Next, I would like to share some lessons that we learned about what works in the private sector through our experience with challenges, failures, successes with our family planning approach. Next slide, please. So one big win for us was that we were able to change perspectives of private providers from family planning as sale of commodities to family planning as a service. So that is something that we see that will work with the private sector, at least in Nepal. Number two would be that for the private providers and owners to take ownership of any intervention or approaches, it is essential that we first offer up the business value of the intervention. Number three would be that the 4-question method information index plus standards are ideal for the private sector, considering time is a constraint for both clients and providers at the private sites. Family planning, we feel, can potentially be an entry point to improve overall quality of care, as improvements in client experience, environment, and even skills for counseling can be utilized across services. And regular coaching and mentoring has been able to support quality improvements, as I was able to share in the previous slide. And these improvements adopted by private owners and providers can be sustained through mechanisms like the monthly provider cluster meetings that the project had initiated, which meets in person as well as interacts through chat groups. And these clusters, they act as peer support groups, which enables us to transition these sites to less intensive engagement stages. Next slide, please. I'd like to end with some considerations that we had in mind while planning our scale up. So adaptive management is on the top of the list. And for us, adaptive management through dashboards have allowed us to spot problem areas and see red flags timely. And the automated digital visualizations are not only available to project staff, but also providers, owners, so that they can be more responsive to changes that are needed. And it has also enabled private sector to self-assess to some extent. And we also use regular pause and reflects and data reviews with partners and stakeholders, and they have been able and these have been integral to identifying new needs and adaptations that are required across new contexts. We are leveraging what worked in the pilot phase, but we are also refining our approach and implementation strategy through dedicated consultations with providers, owners, and clients. And to make sure that the approach is appropriate for the new geographies that we are going into. And for example, we are using journey mapping and human-centered design to better understand marginalized groups in our catchment area to inform counseling as well as community mobilization efforts. Lastly, we actively built linkages that we hope will sustain the changes prioritized and initiated by the project. We are engaging the government regularly on joint monitoring, identifying capacity building opportunities for private providers, and data integration into the HMIS, DHIS2 in a context where the government is receiving negligible reporting from the private sector. So we support the private sector groups also to convene, where we are helping them to understand the importance of quality of care, but also so that they can consolidate and advocate their needs to the local government. So we hope that during less intensive stages and after the project cycle also, these approaches and efforts with the government and private sector will help sustain gains. Next slide, please. Thank you so much. That's all from my side. And if you have any questions, we'll answer them. I also have colleagues from the team who will answer some of the questions on the chat. Thank you.
Thank you so much, Srishti, for sharing these recommendations and considerations for scale up. They're very interesting. I've seen a lot of questions coming in the chat, which is wonderful. If you have any additional questions, please feel free to type them now. It's now time to move to the Q&A and discussion portion. So it's wonderful that we have a lot to discuss that's come in through the chat. Dr. Sharma will be moderating our Q&A and discussion with Estrella and Srishti. So over to you, Dr. Sharma.
Thank you very much, Anne. And it's really heartening to see such a participation from the participants. It's really very good. What I will do is I'll ask questions in alphabetical order. So Estrella, you go first, and then Srishti, and then we'll go one by one. Okay, so let me go to the first question that has been asked. You see, there's so many, I have to go through the list. Here it is. Estrella, can you share what methods were taken by the 119 acceptors? This is a question by Fiona. Let me start with this question, and then we'll go to Srishti, and then I'll come back to you again. Thank you.
Sorry, what's the question again?
Okay, the question was, can you share what methods were taken by the 119 acceptors?
Yeah. What methods? Most of them accepted PSI, an implant. Majority of them are provided implant. And I think 30% of those who accepted the method were using oral contraceptives.
Let me ask a follow-up question on this. Is it usually the same method mix that is common in the prevalent in the population, or is it different in this setup?
Sorry, the questions are not coming clear. It's not coming clear. It's
Okay,
choppy.
my question is, the method mix that you mentioned right now, is it the same? Does it reflect the consensus in the population, general population, or is it different?
Yeah, it is. General population, you mean in the workplace, or in the for the workplace? Most of the employees are using the long-acting method, but for the general population, pills still ranks high.
Thank you.
Thank you.
Srishti, some of the questions have already been answered. I would like to go to one question that has not been answered yet, and it was, what were the incentives for the private providers for quality assurance improvement?
There were no incentives in the sense there were no monetary incentives. What we felt did work as an incentive was that we linked quality of care and high quality service provision with customer loyalty and how that connects with business. So we had, because it is the private sector, we had an improved quality part, so improved technical capacity, but also we had improved business capacity. And I think that's to be like, I think what worked was that to be able to encourage, improvements in quality by linking them to how it would improve business was what worked.
Thank you. The next question goes to Estrella. Estrella, family planning at the workplace is an interesting concept. What are the challenges faced during implementation? And for those who received family planning at the workplace, where do they seek help in case of side effects? Thank you.
Yeah, thank you. Yeah, as discussed earlier, one of the challenges is on the availability of private service providers that are trained to perform the services, because apparently only there are in case there are private service providers, but most of them were not trained on to perform family planning services. So that's one of the challenges. And the fast turnover, there's also a fast turnover of clinic staff of the partner service providers. But one good thing is that the private service providers that were partnered with the company can easily hired a staff and have them trained with the Department of Health and the provincial health offices. And for the next question is on what was the next question?
Side effects.
Side
where
effects.
do they get?
The referral, yeah. And for the referral of side effects, the service provider, the facilities, before they are being granted to license to operate, one of the requirements is that they should have a referral facility. for high level of care. And also for field health accreditation, it's one of the requirements for field health to for the facilities to have a referral facility for the higher level of care. So in cases of side effects, these cases are immediately referred to the partner referral facility of the service provider. And that's what being practiced here in the Philippines. Thank you.
Thank you. The next question goes to Srishti. Srishti, what keeps the private sector motivated to report their data? And also there's a question on someone would like to know how you were successful in changing the perspective. Thank you.
Thank you for the question. I see a lot of questions on data. So we supported the sites with the tools, and we also provided them with a tablet to enter the data. We supported them with a lot of on-site coaching and trainings to be able to start just recording and reporting the data. And as far as integration is concerned into the national system, I see a lot of questions for that as well. How we incentivize them. So for now, it will be interesting to see how this pans out in the less intensive phases. But in the intensive phase, we were providing monthly support. And in terms of data integration, we are looking at integrating data from the health facilities. Right now, that is negligible. But there are a lot of bottlenecks which we are trying to ease out, and we're sitting with the government and the provincial stat focal persons and at the central level as well to figure out what are the issues. And we have the private providers and owners there as well to figure out the issues on both ends. So right now, this is the initial phase where we've gotten the first pilot phase facilities to start reporting regularly. But to be able to scale this up to 811, that's where the struggle would be. So right now, the incentive, there's more than incentive, it's basically a lot of regular coaching. And once we work with the government on figuring out how we can sustain the reporting that comes in initially, is by hopefully adding reporting as part of, let's say, relicensing. That's where we're trying to work towards.
Thank you. Thank you. I see that some of your colleagues are already providing answers in the chat. So that's really helpful. One more point before I go to the next question. This is an experience sharing. Most of the times when we talk about the public-private partnership, it is the partnership of the governments with large corporates. That's what we call private partnerships. But in every country, there's always a far remote rural area or village where most of the times the government facilities do not have staff. But even such small villages have private service providers. And these service providers enjoy the confidence of the local population, and they're really respected. It makes sense for the government, and this is logical. It makes logical sense, programmatic sense for the government to partner with such individual private practitioners or health service providers. What we did was we conducted a brainstorming, a consultation here in Bangkok with a number of countries, and we had invited the government partners as well as representatives from national medical societies. And we came up with an idea, like in polio eradication and immunization, where governments can provide commodities to these individual private practitioners. And these private practitioners in return have to display. They can all, of course, charge their service charges, but they have to display the prices of the services rendered. And at the end of every month, they have to provide data. The next consignment, the next shipment, or the next supplies would only come if data is provided by these private practitioners. What happens is government gets reliable and regular data, and the people get better access for services. Estrella, let me come to you for the next question. This question is about, was there any subsidy to the private sector organizations for provision of these services?
Yeah. As far as subsidy is concerned, the government do not provide subsidy to private facilities, but instead they are the professional fees that they are getting from the reimbursement from the Philippine Health Insurance. I think that that sustains them for their services. And also the health offices, if there are partners, there are partners with the private service providers, they are allocated family planning supplies. So in the case of Mom's Birthing Home and Family Planning Clinic, Jensen Medical Center, they are allocated supplies from the government, because they in turn they will provide what the government would ask from them is the accomplishment report, the accomplishment report, so that this will also form part of the accomplishment of the local government units. So it's only allocation of family planning supplies and the reimbursements from the Philippine Health Insurance, because the health service providers should be PhilHealth accredited in order for them to claim for PhilHealth reimbursements from the services that they have rendered. Thank you.
Thank you. The next question goes to Shrishti. Shrishti, how will you set up quality improvement systems for sustainability after the life of the project is over? This is an important question.
So, like I said, there are two approaches in terms of we're hoping that the gains made will be sustained. Is one, that we're hoping that the private sector, we will be able to get enough buy-in from the private sector to understand the importance of quality. And we have set up provider cluster meetings by municipality, which are working very, very well in order to kind of raise the importance of quality of care and the importance in their business so far. And we're hoping that, once we move to the quarterly, less intensive stages, they will begin self-assessments to some extent. And we're also working with, advocating with the government, we're working with the government to hopefully take on some of the roles for monitoring, so that after the cycle of the project ends, the government will have a greater role in ensuring quality as well.
Thank you. Estrella, the next question is about what motivation has the program provided to both the government partners and the private sectors to drive the implementation and get the results?
Sorry, come again?
Okay. What motivation has your program provided to the government partners and the private sector to drive the implementation and to get the results? Thank you.
Thank you for the question. Well, as discussed earlier, the family planning program in the workplace is a mandated activity, under the labor code of the Philippines and the department order of the Department of Labor and Employment. The Department of Labor and Employment admitted that they don't have the capacity to provide technical assistance to the companies in the implementation of the family planning program in the workplace, despite being a mandatory activity, because they even if they are mandated to oversee the implementation of the family welfare program of the large companies, but they admitted that they don't have the capacity to provide technical assistance to the companies. So with this model, the Department of Labor and Employment welcomed this innovation, because most of the companies claimed that it is difficult for them to set up a family planning clinic in the workplace. One is that they have no trained staff, or the staff that they hire are not capacitated to perform the family planning services. And time comes when the Department of Labor and Employment go to the companies to conduct monitoring. They always the companies will not be able to submit accomplishments on this activity. So with this initiative, the family welfare program of the companies and the Department of Labor and Employment welcomed this idea, because it is there is very minimal, and I think no cost at all, in setting up a family planning clinic compared to the regular family planning in the workplace program that was earlier developed. So this matching model is a win-win situation, because the service provider will get reimbursements, or will be paid through the reimbursements of from PhilHealth, and at the same time, the companies will be able now to implement the family planning in the workplace, which is a mandatory activity by the Department of Labor and Employment. So it's a win-win situation, and the support of the city health office and the provincial health office are overwhelming, because this will also add to the accomplishments of the local government units.
Thank you very much,
Thank you.
Australia. I have some experience with the family planning in the workplace. While it is beneficial to both, to the employer in the sense that they have women will continue to work for a long period of time, trained women, and they will be available for a larger period of time, so increasing the effectiveness as well as productivity. And for the girls and the women, it is they are free from unplanned, unintended pregnancies, so that it really works. The only problem that could be seen, and that one has to be careful about, is a very strict following. Sometimes the employers can pressurize women to undergo long-term family planning methods, to adopt long-term family planning methods against their desire and wish, and which is against the principles of human rights-based approach. So these are issues that one has to be careful about when talking about the family planning in the workspace. Thank you. Srishti, the next question is to you. Did your project include private pharmacies among the private health facilities? If you did, what was your experience? Thank you.
Yes, like I said, majority were private pharmacies. And even at the facilities that we work with, like hospitals and clinics, our primary work, like most of our work, is with the pharmacies, because that's where, in our context, clients come first for family planning methods. So so far, whatever I've shared is applicable across pharmacies and facilities. So that's why I refer to them as sites. If I was to cite any difference in terms of how our experience was with pharmacies versus facilities, the context itself, I think, creates the difference, because in pharmacies, mostly the owners are providers, and that helps to get a better ownership of our interventions and our approaches. Whereas with the facilities, we did struggle, because we're working on technical capacity with the provider and the business capacity with the management. So, aligning everything and also convincing the management or the owners about the importance of quality of care, that was a bit of a struggle. So that's something I'd like to share in terms of challenges as well, because there were questions on challenges. Yeah.
Thank you for everyone's information. Last year, we came up with a new high impact practice on family planning that included private pharmacies and medical stores. So you could also go through them. And I have noticed that we are almost, the time is almost over. The last question to both of these panelists, it is about what were the failures from your program? Thank you. 1 minute each.
I'll go first. I've also written in the chat because there were so many questions. I think the success or the failure would be much more prominent in our less intensive stages, because right now we're so intensively engaged with the sites and we're getting results. So far, that's that's how the pilot phase has been. But once we're in our scale up, we'll be moving the pilot phase to less intensive stages, and that's where we'll see what gains are sustained and where we'll start slipping. But we do have a lot of challenges, like I've already shared, like with the facilities, we were struggling because the providers and owners are not the same. So, different, we're dealing with them on different aspects. So that was a challenge. Also the turnover of private providers, that's been a challenge for us that we've had to work with. So these are among, some of the challenges that we faced so far. And of course, collaboration and with the data integration, I'm sure that's also going to be, there's going to be a lot to share once that pans out, because we're just in the inception of, getting, talking to the government, and the first phase facilities have started reporting, but again, how we're going to sustain that. So these are all the challenges that we'd have to face. Yeah. Thank you.
Estrella, would you like to go now?
Yeah. Well, for the success, the Department of Labor and Employment have adopted the model. So that's a very good it's a good success story already. And the Department of Health also integrated the program in the workplace in their program of activities. And so the collaborating partners are very, very supportive of the program. And as soon as as the project ends, they committed to roll out the matching model to other companies. And in fact, there are a lot of companies who are now willing to implement the matching model. And for the failures, we have also failures along the way, aside from the challenges. So there was this facility that we have already assisted, where we have already completed the process, the matching process. There was already a signed partnership agreement, but there was a change of management. So the change on the management of the hospital have affected the implementation of, or the service delivery in the workplace. So the service delivery was being stopped, and as of now, they're waiting for the management of the hospital to assign service providers who can provide family planning services in the workplace with the workplace or company that they have already a partnership agreement. And also in one of the companies where we thought that we will be able to complete the matching process have declined later, because they prefer to use only to have their employees use natural family planning method. So it is very unfortunate, because the service facility or the hospital where they are partnered is already ready, willing to provide the services, but the company later declined the partnership because they prefer a natural family planning method. So yeah, so those were just one of the failures. And for the challenges, we always look for adaptive solutions in order to address those challenges and still be able to progress where we are heading to. Thank you.
Thank you very much. And I'll just need 30 seconds. There's a question by Dr. Kudi Boya on advocacy and policy. Let me respond to that quickly in 30 seconds. You know, the answer, it's not an easy answer. We do need advocacy to work with the government to let them know that they have limits regarding resources. Maybe it could be limitation of staff. Maybe it could be limitation of finances, funding, limitation of training capacities. So these we need that advocacy, as well as there needs to be a change in policy for developing an MOU with either private sector or private corporates, or it could be private individuals, and also on the modalities of the partnership. These will have to be worked out with the governments need to work on them, and then only a partnership can take place. Thank you very much. And I'm sorry we have gone 2 minutes over time. Thank you.
Well, thank you so much. I think it's okay to go over time when it's such a rich discussion. So thank you all for your very thoughtful questions, and to our speakers for your very rich responses. Before we end today's session, I just wanted to share that we've also put together a collection of resources on this topic of private sector engagement on the FP Insight website. I encourage you to look through the resources. Brittany has included the link in the chat. And if you haven't already signed up for FP Insight, I would encourage you to do so that you can stay up to date on the latest family planning and SRH resources. So with that, I just want to say thank you so much to all of our panelists today, to Dr. Vinit Sharma, Estrella, Jolito, and Srishti Shah. And thank you all of you for attending this wonderful webinar. In the coming days, we will be sharing the recording and the slides with everyone. So thank you all very much, and have a wonderful rest of your day.
Thank you. Thank you, Anne, Erin, and Dr. Venti, and Srishti.
Thank you.
Thank you. Thank you, everyone.